So, you will be assigned to a group of stakeholders, probably not the group of stakeholders that you are a part of, and your task is to solve a problem. So, it's the 6th of May, and the Prime Minister Albanese, announced this morning that our health system is too fragmented and inequitable for people living with rare disease. He speaks the truth, our Prime Minister. He says, I know that the best and most experienced systems thinkers are at the simulation workshop in Perth and can help. More than ever before, a collaborative effort is needed to improve care coordination and whole-of-life care for people living with a rare disease in rural, regional and remote areas of Western Australia. How would you approach this? So this is your challenge. How are you going to do this? And we've heard lots of good stuff and lots of really amazing examples from the Rare Care Centre about how they're doing it. How can we do it even better? So Christina's going to be the sorting hat. So we're going to sort you. If you are number 1, go to the table with the number 1 on it. All right. So you now need to role play and pretend that you are not who you really are, but who your table says you are. And we want you to discuss the scenarios that we showed you before. How will you increase care integration for people living with rare disease? What are the solutions? How are you going to achieve that? So rather than discussing the problems, and we've heard some of the problems, we pretty much know what they are. What are the solutions? How can we make things better? And how can we work together in order to do that? Media, you're doing a great job. The media have come to the Federal Department of Health to tell them a few stories.
When we arrived, there was no one here. They were all on holiday.
They were all on holiday. Typical. The academic is talking. The academic is making connections. All right, so we might just have some reporting back now, and it's very fitting to start with the Federal Department of Health.
Typical of the federal government, we did start in a silo until someone mentioned that we probably should consult, and that took us 5 minutes to have a conversation about who we should actually consult with. Originally, before we decided to consult, we wrote out a plan where we formed a government committee, which took a little while for us to do that. In there were a number of stakeholders who we actually didn't name. And from that process, we developed a framework to roll off to the state for implementation. When we tried to hand it to the state, they weren't there. So we went back to the drawing board and we consulted. We did come up with 2 strategies to begin with on our own, and that was probably more from putting on our lived experience or our original group that we belong to hats. 2 things that we really were keen to do, and these were the things that we sort of discussed with our stakeholders, was the first thing we were going to look at, and even though it's in the current process at the moment, looking at the NDIS Act and the provisions for rare disease within that Act, and if there's any statutory changes that need to occur so that cohort can be supported better by the states. The next thing we also looked at is trying to make the aged care system more equitable for people with rare disease and disability so that we can, support right through the age spectrum of rare disease and disability.
This one's really important when you've got rare disease. We talked with the Allied Health and they said something about no labels, and this is the most important thing when you've got a rare disease is individual care. So we think cancer. There's 5,000 things of cancer. We just focus on the high level, but it's individual care. One person, we need individual care.
I had the opportunity to speak to our GPs, and as you know, they think in terms of 5 minutes, 10 minutes, maximum 15 minutes. And it would be very difficult for our GP to access the information for 8,000 rare diseases. Ideally, there should be a national perhaps even international database that they can access easily, quickly, perhaps via the platform of artificial intelligence, and link that with the medical records of patients. So patients, they are trying to help but don't know where the problem is.
So I think we never actually got around to chatting to our federal counterparts because they were harangued by the media and we didn't want a part of that. So, but we would like them to consider flowing a bit more of the budget WA's way, maybe even like our fair share of the GST. And we would push health as a major budget concern to our finance colleagues. We think there should be better communication we recognise there could be better communication between the state departments as sort of all determinants of health, so meaningful links between Department of Communities, Education and Health. And we thought that a lot of the difficulties we have is with attracting and retaining and education of staff in our rural and remote regions. That's specialists, but also therapists, as I think has been said earlier. And we were kind of looking at that sort of a top-down approach. So if we can keep the carers cared for, then hopefully they will be able to continue that care for the people, like a lot of people with lived experience do here as a primary carer in their families. The same sort of works from a Department of Health level. We did go over and chat to the GPs as well, who probably quite rightly asked for money. And also we chatted a bit about what we could do there, maybe some digital solutions. So if, either better version of the My Health record or linkage between the state hospital systems and your GPs and the private hospitals and private consultants, that would be better. And also the radiology and pathology companies in the regions, if your specialist could view it in real time, that would be kind of ideal. We then went and asked for money from pharma, because why not? But we thought maybe we could use that actually to set up a clinical trials network in WA and to contribute to rare disease research. So if we partnered with them, we've got Department of Health infrastructure in the hospitals. I'm sure all of the structures are there. We just need sort of interested people and a huge lump sum of money. Thanks, pharma, for that. Oh, we got approached by the researchers, who traditionally we don't like to give money to, but we did say we would fund research for novel models of care for the remote regions, and maybe something like, if we could find something, a similar kind of demographic to Australia with large kind of areas to traverse, like Canada or something like that, would be kind of good. Also with an Indigenous population, that maybe they had some ideas that we hadn't thought of yet that might also kind of come across. And then within our department, we think that education is, like on a community level, would be really important. And so we wanted to produce some sort of health promotion department, specifically with rare diseases in mind, and give out health promotion materials to improve kind of the knowledge around rare diseases as a general sort of umbrella, and also potentially, the sub-umbrellas that come under that. And then we thought, well, there's not very many people in WA in general, but if we could discuss with the federal government and the Department of Health there creating national registries, that maybe we could get some more coordination of care across the whole of Australia and maybe access more subspecialised people that have interests in particular kind of rare diseases.
You did all that in 20 minutes, half an hour. That's amazing. Well done, State Department of Health. GPs, how come you're asking the state government for money? What's going on?
We're just hoping for the best. We'll ask everybody and surely somebody will give us something. Our main point really surrounded trying to collate information in any means possible for accessibility, because it's a bit difficult to ascertain what GPs already have access to, because none of us are GPs. So we tried our best, but really it's just, we want some sort of streamlined process and like some sort of database where GPs can go for diagnostic criteria, red flags for patients that they have where their symptoms aren't fitting regular diagnoses. And with that, is the need for education as well, to, you know, enable them to think outside the box if a patient's presentation isn't fitting a normal, like, common diagnosis. What else can we look for? What other options are there? And if we had some sort of database to assist with that, with the diagnostic side of things, and also once that's ascertained, the support networks for patients and where to go to next.
We thought that possibly bringing some of the models from an international context might help the allies regionally. So there is a clinic out of LA called Napa. There's the CNS Neurologica, the Norway clinic. There are places in Netherlands and Italy that do this already. And we're failing dismally, the regions, because we're not looking at it out of the box. So I'm going to pretend I'm an allied now, but I actually do this clinic once a year. I fly over east to get allied holistic treatment, right? So it's not here in Perth. It doesn't exist. No allies are speaking to one another. We're all isolated in silos. We don't really cross-communicate, and there is a huge amount of competition between the clinics, which doesn't help for rare disease at all, because they need a holistic team. So our suggestion is, and interestingly enough, the model that comes out of the US, these guys are parent-centric. So it's parents who've spent their whole lives with really unusual kids who got no help here in Australia. They brought the model out of LA, out of Boston Children's Hospital, John Hopkins and various others, brought it into Sydney, Melbourne, Brisbane's just opened this year, London's online. And basically the sense is people are flying all over the world to attend these clinics just to get a 3-week intensive in feeding or physio treatment or whatever it is. But they triage the children and even some adult cases as well. And they bring the expertise in by selling Australia. So where I'd say to federal government, which I did want to get there, was why are we not looking at visas that are bringing in these allied professionals and selling our regions? Why are we not creating centres in Broome, Kalgoorlie, Albany, Busselton, Geraldton as satellite centres to Perth, centralising the clinic here as an allied in the Perth metro, but then moving these clinicians out to the regions? Because I tell you, go to Melbourne, there are people from Canada and America who've got 2-year visas out of the government that are allied, specialised. They come out of top hospitals. They're training not only students out of the local universities, they're training Australian allied health professionals, and then it's a group thing. So just what you were saying, there's counselling in it, there's psychology in it. They tie into all the various hospitals. They have telehealths when the clinicians are out of their depth. And then they, in the 3-week intensive, basically put this person through there. So I think from a regional sense, if we were to sell the regions for what they are, which is fantastic, have a bit of experience, bring these clinicians into the area, and maybe get Ronald McDonald on board. Telethon. Why are we not creating Ronald McDonald houses for allieds? Why is it only about having it in Perth? So why not put these houses into these various centres, centralise the care around the houses and fly the clinicians in and maybe give them an experience. Maybe it's the wineries down south or the amazing canyons up north, whatever it may be, and bring them into those centres. It's sitting there for the taking, and there's a lot of philanthropy out there that wants to put the money there, but there's just no governance or foresight out of anybody really looking at it. And that then solves the GP problem to a degree. You're flying specialists into those areas. There's somewhere for them to stay, and they can come in and intensify it so that those kids are getting. So we at the moment are flying over east to get our allies. We don't have it here. So I don't understand. And so just to say, it's not just a regional problem. It's metro. It's not solved by PCH, and it's not solved by, especially for rare diseases. And I just want to say one thing that was made very clear here at this table was the label idea, which I think we said to the media, we're tired of being labelled. There's a spectrum in rare diseases. And when you have an allied professional that, yes, the GPs, you guys have a thing where you're looking at a diagnosis, be careful of that. Some of us only have one anomaly where we've had a genetic switch and it's one person in the world. They may be under that classified diagnosis, but they're totally alone in that switch in the gene. So they manifest completely differently. So I don't think it's about having that label. I think the information is important, but even in the allied space, it's about thinking out of the box. And in this clinic, a large part of the Melbourne team didn't know what they were doing for 50% of the time, but they changed the strategy and moved on and dealt with the person in front of them rather than the diagnosis. And that's a big part of the problem with rare diseases, is that we are often labelled and we are not labellable. It's not possible within rare disease. We are all on a spectrum, and I think that's also where the NDIS that needs to be reformed needs to sort themselves out, because it's not meant to be predicated on a diagnosis, but it is. And when we are undefined, we don't fit.
We had to keep making sure we come back to the question again, because apart from our title, which is the rare disease patients or organisations and peak bodies, we are also the families and people that represent, but people that live with it every day. So a few things that actually came up, and then every time there was someone speaking, there'd be more information coming up. Peer support groups is something that is quite extensive in its need, but it also is a huge part of the health system. It's not seen for what it is a lot of the time, and it takes a lot of parents and carers' time and effort to put into that and to build it, and to also go about navigating their own journey with their loved one and then give that support to others. So sharing the knowledge, which I think has been mentioned a few times, but sharing the knowledge parent to parent, carer to carer, and we want to show the evidence that's behind where it works well, so coordinated care, where it works well and how we can replicate that in different states. And in this example, it's WA. Rare disease organisations, patient organisations, and what we could do within those in terms of education and the programs they can run, and empowering the patient or the caregiver of that person to be able to be an advocate or a self-advocate, and encourage peer support, because that brings out more shared information and knowledge and all that kind of thing. Systemic advocacy, so that's when the organisation then takes that next step and tries to make positive change. And then help with that coordinated care, and that comes back with that peer support group. Provide central support, for example, a telehealth nurse who can become an expert in one rare disease area or a couple if they've got many commonalities, and basically becomes a helpline to be reached at different stages of the diagnostic journey or the actual everyday living, and referrals and reports, whether it might be something to write to the NDIS and so forth. And when we're talking about telehealth, we also need to make sure that we're also advocating for face-to-face appointments for these rare clinics, because they are an integral part of that health journey. It gives a real in-depth understanding of not just the person who needs this coordinated care, but the family and how they are needing support as a family unit. Allowing for follow-up appointments, that's something that we've seen as parents and even peer support group members, that a family can walk away with a whole heap of information and they need time to digest all of that. So it's important for that to be also included. And a sense of community, potentially online, but also create atmospheres for a face-to-face event to further that advocacy, further that peer support and engagement, and that sharing of knowledge between families and carers and so on. And raising awareness and expectations, and that goes both ways, as in the advocate being the individual or the family, whether it be a support group, and then managing that expectation. So what we would expect as a family going into an appointment or a care coordinated meeting, and then what questions we can ask, what services are available beyond that meeting, and what we've been told. So that's something else that we've looked at. And then while we were listening to the others, because that's important, we also looked at creating a local community, whether it be a Facebook page or the like, and that would be able to explain the rare disease in its individual rare disease or a combined rare disease promotion, and also promoting community. It would be great to have also part of it the events that could be held in small towns that could then show the advocacy that organisations could put forward for it to be an education and a raising awareness activity for families and the individual themselves to be able to advocate for themselves in their own healthcare. And then we also looked at who we could involve, whether it's in organisations, patient organisations or peer support groups. How do we involve our wider community beyond just healthcare meetings? And the Rare Care Clinic has started that, which is great. But I think also to really get a grasp and understanding of how teachers see it. So in the classrooms, not just at appointments, but how do they see it in the classrooms and how that affects the individual and what further care and support do they need to get optimum learning opportunities in the classroom. And then I think the last one, including case studies, whether it be in person presenting to a group of students at university, so within tertiary education, really embed that sort of shared knowledge, but also an understanding to future teachers, future healthcare professionals, allied health professionals, the importance of understanding rare disease and the complexities and the spectrum that it comes with, and how to be able to then navigate that and then put it into practice when they are out of university and in the workforce.
So we thought one of the key things that the media should be doing is kind of awareness promotion, and that needs to be multi-channel campaigns around raising awareness of rare diseases through social media, print, TV, advertising, and could be in like dedicated segments, programs like Insight, Four Corners, Landline, and should be accessible on all of the different channels so that it's available to rural and regional families as well as metro, so making sure that it covers channels like GWN, WIN, etc. And I think that is also two-pronged. It's that awareness raising, and then there's the kind of expose, shock factor. What's the government not doing? What the real faces of what are families' experiences that could be impacted by the government changing their policy or more funding being available or various things like that. And then there's the role around fundraising. So fundraising from the public, so these are the kinds of avenues that you can donate to or you can contribute to. And then there's fundraising through events and large like philanthropic industry organisations. So like telethon, but not just one day of the year, much broader and continued. And we consulted with our families for our first point of call. We wanted to know how they wanted to be represented in the media. And then we spoke to Allied Health, and then we spoke to the federal government. And the federal government very much said to us they would like us to report the whole story, and they would like editorial discretion over what we reported, which we know that is not how free media operates, so we politely declined.
A lot of what we talked about was around education and training, and trying to incorporate more around rare diseases, around management and things like that into not only training when people are going through courses, but also making sure that it's part of continued professional development so that people are constantly learning new things, keeping up with advances, and just generally kind of staying on top of things, because I guess, a lot of people train and then practice for 10, 20, 30 years and might not get that updated information and knowledge around what's happening, and just keep things relevant. The other thing that we talked about was also improving access to treatments and clinical trials and things like that, and trying to make that more, streamlined, because there is a lot of advocacy from doctors and things about trying to get people into trials, trying to get treatment access, but a lot of that does come down to, medications on the PBS or, things that can be difficult to access. So trying to improve access. Another thing we talked about was also incentives to bring staff to regions, so to the rural and remote communities. Maybe that we have seen examples of that already being part of training, trying to get people out to rural communities to do, some of their training and things like that. Another thing that we talked about was networking and influence. So, of course, people move in circles, people talk to each other. So having specialists, raise awareness at events that they go to, or educational training things, just to keep everyone in the loop, make sure that information is getting disseminated to different people so that people are sharing that and sharing contacts and things like that as well.
We nurses use some innovative methods to source information from other groups, such as families, people with lived experience, allied health professionals, and we really liked the ideas from the GPs around saving money, because we also thought that we could save a lot of money by spending money on early intervention, which would then save costs down the track, And we could also minimise a lot of duplication of services and unnecessary tests. There's lots of really great research that has been done on shortening the diagnostic odyssey, and it would be really great to see those programs funded by the government and actually put into practice. So translating research into clinical care would be wonderful. But bottom line is the nurses would really like a lot more money spent on things like bringing specialists, allied health care providers and nurses to the regions. And we really think that there should be many, many, many more nurses trained and employed as care coordinators, because they obviously sound like fantastic people and who are best placed to cut across all areas of the healthcare system. And if we embed them in different teams like palliative care, rural medicine, there's probably lots more that we couldn't think of on the spot, and putting them where the people are that need the help to try and minimise some of the waste would actually, even though we were spending more money, we would save money overall. And we really wanted to talk to the health economists, and we're wondering why they're only ever seen in research programs and not in assessing actual clinical care programs.
Yeah, great point about the health economists.
Firstly, we didn't go and talk to anyone, but people did come to us to ask for money. We haven't promised any anywhere yet, but we were interested in seeing how we can kind of benefit in terms of getting people into our clinical trials, or people who should be accessing our drugs or medical interventions, how we can find them. So we're interested in funding an international register of rare diseases so that we can see how many people in the world have not just maybe specific conditions, but maybe a collection of conditions that may respond to a certain therapy that we have. And then when we know how many there are and things that we can target, we want to know how we can then get the patients on board, rather than, like we heard, people having to kind of trawl through websites themselves. So we wanted to have some kind of connection with organisations like the Rare Care Centre, so that it may be someone embedded there or some way that we can kind of feed back to them, you have this patient, because we've seen that they're a patient of yours and they're on the register, and we want them to be able to access our trial. And we want a way to make it easier for some rare disease therapies to kind of go through, rather than the long step process that things need. We want a way of getting our medical technologies into those remote areas. So things like, we had an idea of potentially funding a rare disease bus, like other kinds of buses that go to different centres. And we also talked about how can we kind of give incentives to people so that there's continuity of care for those people going out to those clinics. So we thought maybe we'd offer some scholarships for some training programs, with a caveat of potentially doing a certain amount of time working in these remote communities, but then we're not exactly sure how we're going to retain them after they've done that time.
We felt that we need evidence-based models of care rather than, and a lot of what you said tonight, it all could be based around research first. So we need money. That was the top of our list, and we thought of NHMRC, pharmaceutics. We visited them, and I pitched them about how they could support us, and philanthropic donations, and then also potentially research students who are looking for academia to do masters programs. Genetic counsellors always need good research projects. And we needed to first of all look at the stakeholders. Who are the people that we need to engage and to talk to, and what they need to understand the rare care in the rural and remote communities. And we thought of a scoping review. We need to know what's done already. We don't want to invent the wheel if the wheel is already there. And if Canada is a great model of care, why are we not looking there and using what they've done and then tweaking it? Because it can feel very lonely out here in Australia, but we could potentially learn a lot by looking to other research around the world. We really want to engage our consumers and do qualitative research. I think a lot comes from our consumers and meeting with them. We can pretend we know what they want, but until you engage them, you will never know. And a lot of good research this day actually mandates that you actually have to engage consumers and do focus groups in order to get approval. We want to know models of care. We want to research model of care. So we've got one where all the patients come to us. We've got the one where we all go there. But what's outside the box thinking? Can we look at Doctor at Home, a virtual program, AI? What are other countries doing? Is there a multidisciplinary team approach model of care where you see all your practitioners in 1 week? What would that feel like, Christian? Do you know what I mean? Like, as in, what would it feel like if you could see everyone in 1 week? I don't know, is that possible? But it's like dreaming big and what's possible. And then I'm thinking of those mercy ships. Like, could we get a ship? Could we get something to go north? Could we get something to go south? Put all our healthcare professionals on it for a week at a time. I know there is a rural champion at the moment in the space of rare care called the Darcy effect, but could you have rural champions around, and it would be a consumer, it would be someone with a child with a rare condition, and they champion that space in that area and partner with us and does that work. And what does that look like as a model of care? And then we need to publish our papers, because we need to give evidence out there. We need best practice, and it all starts there before we can roll out. Like, we need to know what doctors do want. Like, you can't just say, we'll give it to them. What actually do they want till you go to places? So research, it starts there. Thank you.